Go ahead. Great.
Sounds good. Well, first of all, thank you again, everyone, for inviting us. I am Renee Kroplewski. I am the administrative director at the Share Network. And I am very excited to be here, to be working with all of you. But, I have been working with the program committee and being able to find programs that make sense for all of the village members. And one of those topics that came up was making the most of your healthcare providers. And we know that when it comes to your health and the health of your family, seeing a healthcare provider that fits your needs is extremely important. There's a lot of options, there's a lot of choices out there. So you have to really sort through who to choose from and for what reasons too, specialists, primary care providers, and so on. In addition, then you have to work with your insurance and making sure that your insurance covers these providers. And many of times that coverage or those copays need to be within that network. So Dr. Stacie Levine is here to cover the differences between some of the primary care providers and specialists, including tactics, communications, and other options to help make the most of your appointment time. For those that you that aren't familiar with Dr. Levine, she's a professor of medicine and chief of geriatrics and palliative medicine here at the University of Chicago. She's a senior advisor for our Share Network and a longstanding educator within the Southside community. Dr. Levine is passionate about improving the care of older adults through sharing educational resources and empowering community members and their families. So it is my pleasure to introduce you to Dr. Levine. And for all of you, we hope that you make the most and learn a lot from this program. Dr. Levine, it is all yours.
Thank you so much, Renee. And it's really nice to meet everybody here on this call. Thanks for being here. So I have been a geriatrician for over 20 years. I'm very proud to say that I'm aging along with my patients. And I think a lot about this topic for myself as I think about my own healthcare. I trained in New York City. So I went to medical school at Rush. And then I went to New York City for internal medicine residency. And then I decided to stay there for a year to do a geriatrics training and then transferred to University of Chicago right after 9/11 happened, right before 9/11 happened, and did another year of research at University of Chicago and then stayed on for now until I've been here. It's my first job since I've been after training. So very proud of what I do. I have an outpatient primary care practice in geriatrics at South Shore Senior Center. I do a half a day a week at the nursing home. I also spend some time on the inpatient consult services at University of Chicago Hospital, seeing both geriatrics patients as well as people that have serious illness who are near the end of life or need palliative care. So very broad swath of what I do, but I've loved it ever since. So I'm going to share my screen now. Let's see. Hold on a minute. Very Can you all see that?
It's the Zoom screen.
Oh, it's really weird. Let me stop share. Hold on. Here. How about that?
Yes.
Awesome. Okay. Now I need to go from the beginning.
Slideshow up at the top.
I know. Yeah, the thing is my bar is blocking me. Let me move it. Here we go. Okay.
Yeah.
Here we are. Okay. Thank you for your patience. All right. So Dr. Thompson, who you probably know very well, developed these slides. So I need to give her credit for that. What I'm going to tell you, my disclaimer is I am not a social worker. So if you have all these questions about what insurance plans that you should be enrolled in, I'm not going to be able to answer those. I can speak in generalities about what I've seen in my own patients. The other thing too, the disclaimer is that I'm not going to be able to answer personal medical questions, of course, if I'm not your doctor, but certainly can help with some general themes. Okay. All right. So What are we going to talk about today? We're going to do a little bit of background, reminding you what all age-friendly care is if you haven't heard that terminology before. We're going to talk about how to choose a doctor you can talk to. Many of you probably already have a primary care doctor, but if you're searching for a new doctor or you're advising your friend, you may be able to answer some of the questions as they're seeking out a new physician. Then we're talking about how to prepare for your visit, what happens during your visit, and then after your visit. And I want you to put in your mind right now, typically what you do in these domains for your own primary care appointments. Like, what do you do right now? What's your current practice for getting ready for your visits? What do you do during your visit, or what have you experienced? And then what do you notice after your visit? And we'll compare to what I'm recommending. Okay, so let's start with what is age-friendly care? You may have heard this term before. A few years back, the Institute for Healthcare Improvement and John A. Hartford Foundation got together and said, listen, we need a better process for education and caring for this booming population of older adults that we're seeing. You know, all the baby boomers are getting older, and we're seeing this large number of exponential older adults that are living longer. And we have to really face the issues that we're seeing here and train other people to take care of them, because there's not enough geriatricians. I can tell you quite honestly, that is very hard to find a geriatrician. There are some in Chicago, as that you see me, but there's not as many as we probably need. So we have to train other primary care providers to help care for our aging population. So they created these guiding principles, and they call them the 4 M's. These pillars involve what matters to the patient, mentation, mobility, and medications. And we'll go through those in a little bit more details in the next slide. We also want to talk about performing good care for our patients that's not causing harm, and to make sure that the care we provide really matches with what the patient values, what matters to them, but what also matters to their loved ones. So these are the 4 pillars. The first one is identifying what matters to our patients. How often do your healthcare providers ask you what matters to you when they see you? What is important to you, especially if somebody just got out of the hospital and had a pretty rough course and had, you know, just this really difficult experience. What matters to you, knowing that your disease may be getting a little bit worse, or you may have lost a loved one recently? What are your preferences, including things like end-of-life care? The next one is the big bucket of medications. I think medications are the cornerstone of a lot of things that we see in healthcare. Sometimes the medications we are on aren't as effective anymore as they were when we were younger, or the doses are too big or maybe too small, or maybe we're not using the right medications for our older adults. Maybe we're underprescribing. You know, certain times we have certain diseases that people think, oh, they're too old or they've aged out of treating this certain medical condition. But the reality is we have a lot of good data for things like high blood pressure and even diabetes that shows that aggressive care in certain patients, even when they're well into their 80s, can be very effective. And also making sure that the medications we choose are not interfering with the other 4 M's, the other of the 4 M's. Also, mind is very important. So how do we identify and treat and manage depression, anxiety? What about evaluating people for memory loss? Memory loss is fairly common. And how do we discern that between normal memory and actually dementia? And then certainly people that are at risk for delirium when they're hospitalized. And then the last one is mobility, ensuring that we're walking safely every day, that we're maintaining our function and independence so that we can do what matters. Those are the four pillars. And certainly that's not all that we do in geriatric medicine, but when I go into a patient visit, I'm always thinking of these things when I'm seeing my patients. So take a look at this cartoon. So the doctor here is saying that, or the patient saying to the doctor, let me know if you want to know why I am here. And it's this, feel really rushed. The patient's getting rushed to get on the exam table. You're barely talking to the doctor and they already want to get you into an exam situation. And it can really feel rushed at times, and leaving people feeling like I didn't really get all my questions answered. And that's because primary care doctors on average spend about 20 minutes on your visit, roughly 30 minutes for a new patient, roughly 11 minutes on average for follow-up appointments. We would love to have more time with our patients. I would have a hard time to find a doctor who didn't want more time for their patients. But unfortunately, the way the healthcare systems are designed is that primary care doctors are often paid based on throughput or their level of productivity. They're expected to see, sometimes it's over 20 patients in a half day in a 4-hour period. And that's really not enough time to get somebody who's especially walking with a cane or a walker into triage, to take their blood pressure, to sit them in the room, to maybe get them undressed, for the doctor to come in, to listen to their concerns, to examine them, and then come up with a really viable care plan. 11 minutes for a follow-up is really not enough time. And that's why doctors often feel rushed or they're running behind, and you're sitting there for an hour, sometimes an hour and a half, and you haven't even been roomed yet. And it can be incredibly frustrating, especially near the end of the day. And that's also why doctors often interrupt their patients, and that doesn't feel good either. And I'm certainly not making an excuse, but I just want to show you kind of what we go through when we're really rushed to see patients, especially the high volume practices that are out there now. And also, most doctors do not have special training in geriatrics or age-friendly care. That's what we're trying to do with the Share Network. But there's a long road to go with getting primary care providers up to speed with geriatricians. So how do you choose a doctor? So think to yourself, with your primary care doctor that you have now, and maybe you have somebody who's relatively new, or maybe you have somebody who's been your doctor for over 20 years. If you do have somebody who's been your long-term doctor, congratulations, you must have a really wonderful relationship with them. Oftentimes we get recommendations from family and friends for referrals, rarely on the internet, but some people, that's all that they have. If they move to a new location, they're new to Chicago, they don't know anybody, maybe they go on the internet to find a doctor that's within their insurance plan. Also, you want to consider things like, how far do I want to travel to the clinic appointment? Do I want this clinic to be affiliated with a certain medical center? Am I in the Advocate system, Northwestern system, University of Chicago system, or am I seeing a doctor in a freestanding clinic? And do I care if it's a male or female doctor? I think those are all really good questions to ask yourself. Other questions you can ask the office is, how many older adult patients does your office typically see? And I would venture to guess most primary care practices, whether they're internal medicine or family medicine practices, do have a fair number of older adults, just because of the demographics of our population in general. And also, it may be important to you how you contact your doctor. It's rare for a doctor to give out their personal cell phone number or even their personal emails to their patients, mostly because it's not secure on email to talk with a patient. We oftentimes try to do that through our electronic medical record. But it really depends on how important it is to you. Sometimes it's very hard to get a hold of a doctor. It has to go through a nurse or an answering service. So that may be something that's important enough for you as you choose your physician. And then also other questions like, who can come to my visit with me? Are you allowing a family member to accompany me, or a caregiver? And then other questions we'll get to is, when you get to your visit or prepare for your visit, is having enough time to ask your questions. Do you feel that the doctor is somebody who's open to listening to you? And can you understand what they're saying? Are they speaking in a nice cadence for you? Are you hard of hearing? Is there any sort of other barrier for you with communication? Because obviously we want you to leave the appointment feeling very satisfied that you have all the information that you need. This is another funny cartoon. The doctor will see you now. I can't promise that he'll talk to you, but he'll see you. So I wish it wasn't like that, but sometimes it really is. It does feel that way. Okay, let's talk about how to prepare for your visit. And this is a good one. I get a broad swath of people doing different things. And I do like it when my patients come in. Let's say they have diabetes or high blood pressure, and they bring in a list of their recent blood pressures or their blood sugars. I think that's so helpful for a doctor to have that. It's also very helpful to consider bringing in your medications with you when you're on your way in. And I also have patients that come in with a list of questions for the doctor. I think that can also help organize the visit a little bit in advance. But for new patients in general, it's, why are you here? What we call it the chief complaint. Why are you here? And then we have something called the history of present illness, where we ask the patient more questions about that chief complaint. So if you're coming in with pain, it's where is the pain, and to describe the pain more fully, and what have you used to treat the pain. So there's a series of questions that we're compelled to ask about that chief complaint. And then also for new patients, we want to know what your current medical diagnoses are. So if you heard of your medical history, that's great. Whether it's surgical history or medical history, have you been hospitalized before? What was that for? And have you been seeing previous doctors somewhere else? How can I get those medical records from them so that I can have more data? Also, we ask about family history, even if it seems like it's irrelevant to you. But it's important. Like if there's concern about memory loss, is there a history of dementia in the family? Is there a history of heart disease or cancers, high blood pressure, diabetes? And what family members had these illnesses is very helpful for us. I mentioned medications, and that includes even non-prescription medications. So if you're taking any vitamins or minerals or anything over the counter that is not a prescription, we do want to know what that is. And herbals definitely can interact with other real medicines. An example I have is a patient that had cancer and was starting chemotherapy, and she was taking a lot of herbals as supplements. And I had to go through and go online. There's an online system where you can compare the herbals and see if they interact with your pharmaceuticals, and found out that she had drug interactions, and her chemotherapy wasn't going to work very good if she continued these herbals. So it's very important that we know everything that you're taking in your mouth, just so we know that there's not drug interactions or drug disease interactions. And also, if you're using topical preparations for pain, things like that are also very helpful for us to know. And then also what kind of behaviors you have. We call it your social history. So are you a smoker? Are you a current or a former smoker? How many packs a day? Are you using vape products? Are you using chewing tobacco? Are you drinking alcohol? How many drinks per day? And do you use any illicit drugs? Medical cannabis is very popular these days. I have a fair number of patients in my practice that use cannabis for pain control and for sleep and anxiety. So it's important, if they do, for them to let us know. And also, what kind of physical activity are you getting? The recommended weekly allowance for people that can ambulate and do physical activity is about 150 minutes per week, which is 30 minutes a day, 5 days a week. That's the minimum that we ask of our patients. So I would love to know what kind of physical activity people are doing. And then, how functional are you? Are you able to maintain your daily activities? Do you have somebody helping with housekeeping? Do you have a family member coming and taking you shopping? Are you driving? Those are all really important behaviors that we want to know about. And then also, have you had any significant life events? I've walked my patients many years through loss of a spouse or a child. And so it's good for me to know what's going on in your life. Or is it somebody that recently retired and is getting accustomed to now not working? Those really are important for me to know. And then the return visits are generally a lot shorter, as you've probably experienced, because we already have the basic information. But similarly, I would want to know, why are you here? Are you here just for a routine appointment, just a checkup, or are you here because you have a new concern? What happened since your last visit? Were you in the hospital between now and then? Did you see any specialists that I should know about? Any changes in your physical health or mental health since our last visit, or any changes in your medications or other significant life events? So those would be good to come in with, because I'm certainly going to ask you about them. And then, of course, the age-friendly concerns: mood, physical or cognitive functional problems, loneliness, any sensory issues, like if you're losing your hearing or your vision is off. That would be good for me to know as well. And keep in mind that most primary care doctors, as I said, are not trained in age-friendly care. So you may have to be the one to bring them up. As far as your concerns that you bring in, try to prioritize what's most important to you. If you have a long list of concerns, like 12 complaints, maybe try to prioritize the 1 or 2 most important things on the list, because your doctor may not be able to get through everything in one day. So prioritize your chief complaint. What worries you the most about that? And then also keep in mind that if there's certain topics that people might consider to be sensitive, as doctors, we are trained to ask about everything. Okay. We are trained to ask about your sexuality, about urinary incontinence, about stress in your life, but not every doctor is going to bring it up. And if it's something that's really of concern for you, then please do not hold back. I mean, don't believe that your doctor is going to ask it necessarily. If it's important to you, please bring it up so that we can take more history and get to the bottom of what's going on. Also, let's see, I think I got through all the rest of these though, but again, bring a short list and prioritize your concerns so we can make sure we address the number 1 and number 2. I mentioned bringing in all your medicines. If my patients bring in their medicines, I'm thrilled. Bring it in a bag, including over-the-counter stuff. I mean, you may not have to bring in Tylenol necessarily, but either bring in all of the medicines or bring in an updated medication list so that we can be very clear about what you are taking, especially if you've been in and out of a hospital and or going seeing specialists and people have changed things and we may not have an accurate medication list. If you have information like lab tests or test results from another doctor, if you have a printout, that's lovely. I love that because then I can just put it into the medical record. If you have advanced care planning documents, like you've recently updated your power of attorney because your power of attorney is no longer available to be your power of attorney for one reason or another, then yes, please, let's update your power of attorney so we have something that's more accurate. Those are all really good things to have. Or if you filled out a PULSE form, a DNR form, then absolutely you want to include that in your medical chart. And if you happen to be expecting or sharing some kind of serious news, let's say you had a test like a CAT scan and there was a concern that there might be something going on there that could be cancer as an example, or heart failure on an echocardiogram, then, consider who you want to have in the room with you. And lots of times people bring note takers with them. It's not uncommon for my patient to bring a daughter or a son and they sit there and take notes for mom or dad so that everybody has all the information and there's not mass confusion afterwards. Like, what did the doctor say? I didn't catch that. Okay, during your visit. Okay, how do we maximize if we only have 30 minutes together, 20 minutes together, how are we going to make the most out of the appointment? Well, you got a lot of what I already said, but let's say you're there because we're going to be talking about doing a test. The doctor recommends a test. Well, what is the test for? Why are we recommending it? If it's about a procedure, you're going to go and have a breast biopsy. Well, what is the level of experience of the person who's doing this procedure, and how will I get these results back? Are they going to come through me through the chart, or is somebody going to call me? How am I going to find out what the results are? If it's a treatment recommendation, why do I need this specific treatment? Why are you recommending that I start insulin for my diabetes now with my A1C at the level that it is? Are there any other alternatives to going on insulin? Can we talk about that? If you're going to have a medical procedure, what are the possible complications of the procedure? And where do I go to the hospital? Let's say I join a new practice. What hospital are you affiliated with? What hospital do you rotate at or do you practice at? Where would I go if I have an acute emergency? If somebody's prescribing you a new medication, write it down. What's the name of the drug? Because the drug names are not easy to remember at all. And then what are the anticipated side effects? What are the common side effects? What are probably less common? And keep in mind that medications have to list every single side effect under the sun, even if it would occur in less than 1% of people. And this is where I get tied up in conversations with patients sometimes is we talk about a medication and then they go to the pharmacy and they pick it up and they're like, oh my God, Dr. Levine, this medicine has way too many side effects. I am not taking this medication. And I'm like, okay, let's talk about like really what could possibly more likely happen and what's less likely to happen with this particular drug. Because that does happen sometimes. People say, I'm not taking the medicine and they don't tell me that they didn't take the medicine. So yeah, take notes. That's always helpful to take notes. A lot of this has already been said, but let's see, really good, important to talk about diagnoses. I think if I could possibly spend the most time with my patient, if I only have 30 minutes for a revisit, it's to do a lot of counseling. I like to do education, patient-related education, because there is a lot of room for misunderstanding that can happen if people are not communicating, if we as doctors are not asking you if you're understanding what we're saying. I know a lot of times, like my parents are like this, they want to be a good patient. And so they'll go into a doctor's appointment and the doctor will tell them all these things. And then they come home and I said, well, what happened? And they're like, my dad's like, I don't know. I just shook my head and I just figured the doctor will figure it out. If something's wrong, he'll let me know. And it was like, well, Dad, we should really try to empower you a little bit more to write stuff down and ask some questions. So it's really okay to say, when you're talking about spinal stenosis, well, what is that? Can you show me my MRI? Can we look over that together? And you can show me where, or my osteoarthritis of my knee, you're recommending a knee replacement. Can you show me the x-ray and show me where it shows that I need to have a knee replacement? I think surgeons in general are pretty good at showing imaging so that the patients understand that they need surgery. It really helps to see that, but definitely having the doctors explain in layman terms what is going on so that you have a better understanding of the treatment options. Okay. And then yes, being honest with doctors about habits, like I'd mentioned before, it's totally okay to be honest with doctors about, like Dr. Levine, I finish off a bottle of wine every 2 days. I'm a little embarrassed to tell you that, but I want you to know. Of course I want to know, or if I want to know if people who are still smoking, even though they've been told not to smoke, it's much better to at least let us know what you're doing so that we have the full information. We do not judge. I do not judge, what people do. It's what they do in their life. But I can't help you if you're not being honest. All right. Okay. Also during the visit, definitely ask for explanation or clarification if your doctor attributes something to normal aging. Like that pain you're having in your back, that's just normal aging. Or that skin lesion that I'm looking at, that's just normal aging. What do you mean by normal aging? Can you explain to me why this is normally an aging and not something you might find in a younger patient? Another common one is saying to the doctor, I'm concerned about my short-term memory. I'm noticing I'm not as sharp as I used to be. And a doctor may say, well, that's just normal aging. That's just what old timers get, whatever the slang is for that. Well, no, I mean, dementia is something that people worry about more and more as they hear about it. And it's good for patients to understand that there is, as we get older, and this happens to me, I'm middle-aged now, and I can tell you that my processing speed is a little slower than it used to be. That I have word finding issues sometimes. I walk into a room and I don't know what I'm doing there. I'm like, oh, where are my keys? I mean, that happens normally in people as we get older, and it's not fun, but that doesn't mean that there's something wrong with your brain. We know that as we get older, our verbal abilities actually get better. So that's one good thing to think about is, have you thought in your own head, like that you actually speak more articulate now than you did maybe when you were 40 years old? There's actually some truth to that. We become more articulate as long as we are practicing our verbal skills. And that's why being part of a senior center like this is really good, because you're using your verbal skills or talking to your friends on the phone. That's really good. It's like exercising a muscle. It gets better over time. But there is some mental slowing that happens with normal aging. What is not considered normal is if you are really struggling with taking your medicines every day. You're missing pills, or you're double taking because you forgot that you took them already, or you might have burned food on the stove because you left a pot going, or your finances are all a mess because you're not paying your bills the right way because you're either forgetting or you're double paying. I mean, all that stuff is very concerning enough to go see a doctor about that. And then to really identify what is the proper workup for somebody. But I rest assured, not every single concern about memory, short-term memory, is actually something worrisome. And I do spend a lot of time really counseling and showing people what's normal and what's considered not as normal. Okay. And then other issues too, that require further conversations are things like I mentioned, pain. Pain is a very big term. It's hard to come in and say, I have pain, give me medicine. No, it's like, what is causing this pain? Is this something that can be treated without giving you a pill? I do not like giving pills right away. It's really all about what's the source of the pain. Is there something we can do that doesn't involve medication? Or if you're having falls, that's a big concern. That's not normal aging to be falling all over your house. Then is there something wrong with the way you're walking? Is it something wrong with your eyesight? Is there something wrong with your structures in your house? Do you have loose rugs? Are you having any mood changes or trouble with your holding your water or your bladder control? I mean, those things need to be discussed. And then, of course, I mentioned hearing and vision changes. People can do a lot better with having their eyes fixed and having hearing aids if they're willing to do all of that. Okay, and then after your visit, that we do these after visit summaries in our Epic system. So sometimes I'll put patient education information in the after visit summary so you have something to read when you go home, especially if it's things like back exercises or how to treat osteoarthritis. And so go home and read those. Go home and read and see what future appointments are and put them on your calendar so you don't forget. If you did forget to ask a question, again, ask your doctor, how do I get a hold of you if I have a question after this visit? That's totally fair game. I love when patients message me through my chart, as long as it's not an exhaustive, like everyday kind of conversation. But certainly it's better than trying to call my office sometimes and trying to go through a nurse or expecting me to give out my cell phone number or my email. Cause I just really don't like to do that. Cause I get 100 emails a day and I'm likely to miss it. And then again, prioritizing your questions and reviewing the notes with your family so that when your daughter or your son or somebody else calls you, says what happened at the doctor's office, you're fully prepared to tell them what you got out of the visit. If you experience any side effects or other problems with your medicines, please don't just stop them and not tell anybody. I got after my father for doing this recently. He just decided on his own he wasn't going to take a certain medication, but he didn't tell his primary care doctor. And it's like, well, you can't really do that. If your symptoms do get worse, despite getting treated for whatever your symptom was when you went to the doctor's office, make sure you contact them right away. If you receive any new prescriptions or start taking any over-the-counter medications, make sure your doctors know even before you see them, because months can go by and you've been on something and we weren't aware of it, especially if we need to do drug refills, because we need to know that we have a record of that. And usually for me, when I do blood draws on my patients, I don't call them or send them the results, because that is a lot of like mail or a lot of conversation. Oftentimes I'll say, if you don't hear from me, consider that your labs were normal. That's not what every doctor does. Some doctors do send results to their patients. They have an automatic system that does that. So it's really important for you to ask your doctor how you're going to get the results of your tests or of your blood work, so that you know if it's going to come to you. And if you use an electronic medical record like my chart, you should be able to look them up yourselves, which I think is really good. Okay. And of course, we're not always happy with the care that we're receiving. Healthcare has changed quite a bit in the last couple of years with the pandemic, and we're trying to crawl our way out of healthcare resource deficits. We're missing a lot of nurses, let's say, and it's been a little challenging to say the least. So I definitely sympathize if you have some concerns about access to care and quality of care. I think we can all talk about how things have changed a little bit. I think it will get better, but it's going to take a little time. But if you are seriously concerned, there are ways to file complaints, calling the hospital they're affiliated with. The ombudsman is another example, but certainly starting with the supervisor of the medical practice would be probably the first recommendation, because they may be able to fix the problem without having to go above them. Okay, so we'll have time for questions. In summary, it's great to prepare for your visit. Make a list, bring your medicines, bring your questions. I think that really helps make things go by more efficiently. But again, prioritize what you want to talk about in case you can only get to the top two things. Definitely ask clarifying questions. And be aware if somebody's chalking up to something, it's just because you're getting older. Well, then please explain to me what you mean by that. And after you're done, summarize the visit, review any instructions, make sure you don't miss anything. And then, of course, advocating for age-friendly care. Tell your doctor what matters to you. Tell your doctor any concerns you have about medications, your mobility, and that's about it. So I will stop there, and I will stop share so I can see you and see if you have any questions.
It's a great presentation. I don't have any questions.
Looks like Terry does.
Yes. Two things. One, several years, about 25 years ago, I fell and injured my shoulder, and my primary care referred me to the orthopedic clinic, and this was at Northwestern. And so I called, and the receptionist said, "Do you want to see a surgeon or an internist?" And I thought, well, if I see a surgeon, he or she's going to want to do surgery. So I said an internist. So sometimes you have to sort that out about what you think, because I figured that an orthopod internist would do referral for PT and that kind of a thing. And then if necessary, refer me to a surgeon. But then secondly, this has never happened to me, but it is of concern. It could be of concern at some point in time. And that is if I'm not happy with a certain visit or a specialist, and I want to seek a referral, a second opinion, I should say, how best to approach that with the person you're seeing, or go out on your own and find somebody?
Well, that's a really good question. So, as far as getting a second opinion, you are absolutely entitled to that. In fact, I often encourage it for certain conditions like a cancer. A new diagnosis of a cancer is sometimes the treatment might be different from place to place. So it's always, if you are in an area like Chicago, we're very lucky. We have a lot of different medical centers, so people can try getting a second opinion somewhere else. Or if somebody's recommending spine surgery, maybe pick two people, or to get a couple opinions just to make sure that you feel comfortable with the spine surgeon. That's perfectly okay. But yeah, I don't think people get upset if you're like, I would, maybe we just don't have we're not jiving one way or another. I'm looking for another person in the practice. Sometimes it's calling let's say it's an endocrinology practice and they have 5 endocrinologists, and it's okay to say, next time you schedule me, can I try somebody new? And that's with the schedulers. Or when you're in your primary care office and you're saying, my cardiologist, they're leaving, or they're kind of retiring and they're not around as much. I would like to get somebody who's more available on certain days of the week, and they'll probably be happy to give you to somebody else. So those are suggestions. Renee's sharing a tip sheet to help you that you could download to your computers.
Yes, it's a great tip sheet that it goes over the 4 M's that Dr. Levine was discussing early on in her presentation, and it helps you talk about all of those different important areas with your provider. So it's something good to review, be able to take with you, and it also helps you be prepared with any questions that you may have. So just, something that's an easy, quick thing. Oh, I'm going to take this with me, for new or even reoccurring visits.
So I have another question.
I just wanted to say, I've been going to the University of Chicago hospitals for over 40 years and basically very pleased with my care. We are very fortunate to have a very good primary care doctor. But it does get confusing because as you get older, you start to see specialists. And I'm never quite sure that the specialists communicate with one another, and so it does, and I have a PhD, so, but not medicine, of course, but keeping track of it all and trying to make sure you're communicating with the various doctors so that they know all that's going on. I mean, I remember the good old days when our general practitioner even came to home visits, right? Now those are gone forever. But the communication and how to deal with the whole person. And I recently saw a specialist who I decided doesn't see many older people. He didn't, compared to our primary care doctor, he really didn't know how to talk to somebody who was older with more experience, so forth. So there are differences. And
yes,
of course, we have to then become prepared, right?
Yes. I would say it helps when all the doctors are within the same healthcare system. We do have something
Yeah.
called Care Everywhere in our Epic charting, where some hospital systems do post and they use the same EMR. And I can find notes from, let's see, if somebody's in the Advocate Health System or they went to Northwestern, I can find those notes, but not every system uses that. So sometimes I have a patient who got out of the hospital somewhere and I have no idea what happened to them. They're just kind of paraphrasing what they remember. And then I have to, it takes a while to get the medical records sent over. So I don't necessarily have all the information that I need on that day. So if they're all in the same healthcare system, that helps because we can at least read each other's notes. Now, as far as doctors communicating with doctors, you're absolutely right. Some are better than others. I can tell you my father, I keep using him as an example because he went through a recent health issue, but it was just that, where he assumed that the infectious disease specialist was talking to the urologist. And so he had an appointment that got canceled and they all thought it was my dad's fault. Like, your appointment got canceled because you canceled it. And he's like, no, I didn't. I thought you guys talked to each other. So I, again, was like, Dad, it's really important to write things down. And when you go to your doctor's visits, you unfortunately have to do some of this care coordination because you need to make sure that people are having all their information that they need. And it's unfortunate that that's the way the world works sometimes. But if you have more control over yourself and you're in the driver's seat, that's great. Terry?
Yes. I can't remember the term now, but some people who can afford such stuff go out and they forget their healthcare insurance and they find a private practitioner who you pay a certain amount of money and he or she is your doctor, and I think they even do home visits. How, if somebody is interested in that and can afford it, what's the pros and cons, or what should I make sure that I'm not getting myself poor care?
So you're talking about concierge medicine.
Yes, concierge medicine. Yes.
Yes. Yeah. Lots of medical centers have that. And then there's definitely private practice clinicians that only do concierge medicine because they charge, let's say, and I'm just making this number up, but they say, if you give me $15,000 a year, I will be your concierge doctor. And therefore I only need to enroll 30 people or whatever in the program. They still bill Medicare and get paid for their services, but it's like this additional charge that the patient pays to have a doctor with a much smaller practice. And the give and take is that the doctor has to be pretty available to this patient. I mean, if the doctor's going to be on vacation, the patient wants to know when you're on vacation, who's covering you, and can I call you all hours of the night because I'm paying you for your services. So I would say it looks like a shiny penny to some people to have that, but you want to definitely do your research and maybe ask for a referral, like a reference. Like, do you have other patients in your practice that I can talk to see if they're satisfied? I don't know if they'll do that, but I mean, I would just make sure that it is really going to be somebody that's worth the investment. Because once you spend that money, it's gone. And if you're not happy, you've spent $15,000 and then you're like going to a different doctor anyway. There's a chat. Wait, let me do this in order. Let's see. I've got Sel has a question, and then I'll go to Beverly next.
Sel, you need to unmute yourself.
Sorry, I couldn't
Unmute your. There you go.
there. Okay. What about, would like to be included when doctors are talking to each other about me. All right. And I'm providing the organ, so I see doctors are reluctant to do that, and I understand for various reasons. How can I, like, my primary care wants to talk to the ortho doctor or the nephrologist or something like that. I always ask if the doctor, if it's a new doctor, will present, the resident, if they'll present in front of me, because there's so many times that the resident won't, it just won't get things quite right. And it's helpful I don't know. I know it's a teaching hospital, but it's helpful for me to know when information's been passed. That was two questions. I'm sorry. Forget about the second one. The specialist, when the doctors are, doing a little, let's talk about this and discuss this. Shouldn't I be involved in that?
Yeah, so I like that. I find that patients do like it when I go in, I bring the resident back with, we're talking about a teaching hospital situation, right? So the resident goes into clinic, sees you, evaluates you, examines you, then comes out of the room and talks to the attending doctor, and then they go in together. I mean, everyone's different. My practices may be different than someone else's, but usually I will go in the room after, and I will, the resident, are you comfortable presenting in front of the patient? We should go in, and patients tend to like that. They like to hear what you talked about. They like to fill in the gaps if the resident missed something, or the medical student. And then when it comes to like wrapping things up, the counseling part of it, the education, then I get to hear the resident do it in front of the patient. And also I get to include more things and make sure that the resident's using language that is not over medicalized, because sometimes we do that. We're saying things and the patients are like, I don't know what he just said. And so we try to make sure that the patient is understanding, and that takes teaching and modeling. So I do like that. And it's okay for you to say, hey, do you mind when you come back in? Can you present in front of me? I really would enjoy that. And then also it's totally okay to give them feedback. So medical students in particular are really brand new at this, and they're really nervous. And I will ask the patient how they did in front of them. Can you give him some feedback? And it's the students really appreciate it. Hearing from you is saying that, you did a really good job. You were patient with me. You answered all my questions. Or when you are interviewing me, make sure you speak a little bit slower and more clearly, because I have some hearing loss and I can't hear everything that you say. Beverly?
My primary care physician is retiring next year. They told me to start looking for a new primary care physician. I've been trying to find what is the best way to look for a primary care physician for older people. I tried to look, and many of them are not accepting new appointments. And so is there a list, or there's a website that I can go to try to find a primary care physician in Hyde Park at the University of Chicago?
Yes, that is a great question. So there, I would absolutely go through you could either do it through the portal if you use the electronic medical record like my chart. There's ways to do it through that, or you would call the general number and have them get you in touch with the primary care group. Or if you wanted to go to South Shore Senior Center where I work, the patient portal will get you a new patient appointment. That's generally how it works. So there should be somebody. Now you may not get the person you want. Let's say you're like, I heard great things about this particular doctor, but they may have closed their practice to new patients because they're overwhelmed with too many patients. And the last thing you want is to have a doctor who can't see you on a regular basis. I wouldn't want that for myself. So that's the only caveat.
So you said to go to my chart?
So my chart, there's a way through my chart to log in, and there should be a way where you can request a primary care appointment. And then there's drop-down menus, and they may even ask you what location you want to go to, if you want to stay in Hyde Park or if you want to go to one of the other satellite clinics. And then you'll see how to do that. And then it'll show you.
And what was the second one? And what was the second one you mentioned? You said some kind of website?
Oh, no, just calling the general number for the University of Chicago and asking for a primary care appointment.
Okay.
And then the person on the other end of the phone will direct you.
All right, thank you.
Can I jump in on that one and piggyback? The other thing is, I know in instances like where my provider has left, I've also said, who do you recommend? Is there any other practices that you know of? Are there any other physicians that you suggest, that maybe I look into? So that's always a good question. And if neither of the suggestions where Dr. Levine had mentioned about going through the university and things, there's always your insurance. It's a little bit more inundating and it's a little bit more difficult to go through, but they also do have lists of providers available to you. But the university and my chart is always your best bet.
Okay, thank you.
Yeah, when doctors leave the practice or retire, in general, we send letters out to the existing patients, and they may either say, here's your new doctor, or here's a number to call to get a new doctor. So it would be unusual for them to just say, you have to find a new doctor and you're kind of out of luck. You're on your own. They should be assisting you. Any other burning questions? Okay, well, I think,
I would just make this comment, and my experience is at Northwestern, which is neither here nor there, but it does seem like a lot of physicians like ourselves are aging out. You have to figure out how to find another doctor.
yeah, it's true.
And then, of course, well, I don't know about you, Chicago, but at Northwestern, they have some shortages. And so, like my annual Medicare physical,
Mhm.
I usually call in December for January. I called in December. I have an appointment in April.
Yeah.
It's like because of staff shortages.
That's a really good point. If you have a doctor who's really busy and you have to call and cancel your appointment, it could be really hard to get a new appointment in like 6 months, or you may have to see a nurse practitioner, and that's just kind of the way it
Yeah.
is. So just be prepared. I have patients that'll be like, "Can Dr. Levine squeeze me in? I'm going on a family vacation. I have to cancel my appointment." And they're like, "Well, if we get a cancellation, we'll call you." But it's the last thing we want to do is add patients onto our already busy schedules, and then the existing patients get less time with the doctor. We really don't like to do that. So just be very mindful when you have to cancel an appointment that it's for good reason, and be prepared to not be able to see your doctor for a while.
And
Dr.
then
Levine,
before-
I really want to thank you. This has been so informative.
Thank you.
I think the big takeaway is really you have to be involved in your own healthcare. You can't just walk into the doctor. You have to prepare and ask questions.
And write it
But it's
down.
been- writing it down.
Write
is a
everything
good
down.
idea.
It really helps. If it helps the communication from doctor to doctor. If you're going from one appointment to the next and you're talking to one another, you've got notes. Dr. So-and-so said this about my heart. And in here, I wanted to, and then it's hard to ignore that you have that knowledge already. So then it helps them understand that you already know what's going on.
Well, it's been super helpful.
Before we
anybody else
close, Dr. Levine mentioned cannabis. And so I put in the chat that on April the 10th, which is National Cannabis Day, we have a special speaker from UChicago who will be talking with us about cannabis, recreational use as well as medical use. And as Dr. Levine said, many older adults are now using cannabis for assisting with pain control, anxiety, and sleep. So look forward to that, April the 10th, 2024.
Thank you, Terry. That's a good reminder. Yes. Well, if no one has more questions, I just want to thank you so much. It was really very informative, very helpful, and it's what we need. So very good.
Happy to
Thank you.
help. Thanks
Yeah.
a lot.
Thank you.
Take care.
And I think